Well, should we get going then,
Sure.
Dan or Will?
Yeah, so greetings all. My name's Will Harper. I'm one of the hosts of the town hall tonight, along with Dr. Dan Hidaka and uh, Debbie and George. So what I want to just do is just a brief overview of Zoom. I've been on a few of these over the past couple months, more than I ever before. And one of the challenges sometimes with Zoom is different people having sound noise that can disrupt things a little bit. My daughter today was in a class and I got a message saying the music in the background was too loud and could she turn it off? And I bet it was my son playing saxophone. So, that was easy to turn off. So I'm going to mute everybody except Dan and Debbie and George. So, but if you have something to ask, just unmute yourself and go ahead and ask a question. The other way to ask questions as we're going along is to use chat. So if you don't know how to use chat, a dialog screen at the bottom. So if you use your cursor, you can click on the chat and it'll pop up to the right for you. And if you have a question that you just want to type in there, you can just send it off and we'll try and field as many questions as we can. So I'll talk a little bit more later about me and the practice and how we do what we do and why we do it. But I do want to throw this to George, who's going to kick us off.
Thank you, Dr. Harper. And thanks everybody that's joined here. Just for those of you that know us, we have been, as concerned as many, and, I think anxiety and other emotions come into play at this time with this virus. And in talking to our good friend Dan Hidaka, and also he had spoken very highly of Dr. Harper and joining his practice, they have been very focused on it too, and all have offered to do this tonight. And so in addition to us getting really the latest from those that really know what they're talking about it, all politics out of this discussion, we're going to learn a little bit tonight. I think this is a given opportunity, if you have a couple of questions, to put those up on the table. And at the end, I think they're going to talk a little bit more about something that many of us are interested relative to concierge medicine and how that can help in your overall health plan as we get to a point where we cross many functional specialties. So with that, I'll turn it over to you, Dr. Harper and Dr. Hidaka, and maybe if you wouldn't mind giving a little bit of an introduction of yourselves and your background for those that don't know you.
Okay. Debbie, were you going to say something, or you want me to?
Oh, I was just going to say, on the more, we've known Dan Hidaka, it's Dr. Dan Hidaka, but we've known him for a long time, first as a friend and a neighbor. And he's just the go-to guy we always call to for any health issues at all. And what I've really liked about him since he's become a doctor, and I've watched just his practice grow, is that he's really like an old-time doctor. He's very compassionate. He spends time with you. He's different than what we see in medicine today, and he's really thinking about people as a whole person, the whole health and how to stay healthy instead of just fixing when you're sick. But I talked to Betsy, his mom, which a lot of us know, and she was talking about him doing these town hall meetings, and I kind of asked her, do you think he'd do one for us, just to get some of us, more information and knowledge. So I'm just really grateful that you took the time to do this for us. So.
Yeah, no, I'm happy to be here. I'm thankful for those kind words. To talk a little bit about myself, I'm a native of Glenview. I think we've got a lot of North Shorers on this phone call. And people that probably know my family were a little bit, notorious is the wrong word, but our notoriety in Glenview stems from the fact that one of the planes from the Glenview Naval Air Station, when it used to be here, crashed into our home. I got to we got to stay in a hotel for a couple months, which was a novelty at the age of 11.
Nobody was hurt.
Nobody was hurt. Well, the pilots didn't make it, but nobody on the ground was hurt.
Sorry.
I did my high school at Glenbrook South. Subsequently, I went to the University of Illinois at Urbana-Champaign, received degrees in bioengineering and biochemistry there. And then I matriculated at Northwestern University, the Feinberg School of Medicine in Chicago. Subsequently, after that, I did 3 years of residency training in internal medicine. And for those of you that aren't familiar with internal medicine, it's a primary care specialty. We really pride ourselves on kind of being the lone constant for patients as they try and navigate this increasingly complex healthcare web. We're thought of as jacks of all trades. We know a lot about a little, but also a little about a lot. When it comes to core diseases like cardiovascular disease, diabetes, hypertension, liver and kidney disease, those are kind of in our wheelhouse as we are there with patients, navigating subspecialty care. It's difficult because care is getting more and more fragmented, and I think the value of a good internist can't be overstated. I continue to make my home in Glenview. My wife is a pediatrician. She works at Lake Forest Pediatrics up at Lake Bluff. I have 2 small children, a 5-year-old and a 7-year-old. And I should mention that I've been in practice downtown at Northwestern for the past 10 years. In the last year, I started my own concierge practice downtown, but subsequently was recruited over to Harper Health by Dr. Will, who's on the phone call here. And he's given me the great opportunity to establish a practice in the North Shore. So we just recently got a temporary space at Skokie Hospital that I'm going to start seeing patients out of as we look for a more permanent space. We also have locations in Streeterville, downtown in Chicago, where a lot of my patients still reside, and I see patients downtown. But we also have a Hinsdale office out in the western suburbs. So I'll pass it over to Dr. Harper. You can talk a little bit about Harper Health and about concierge medicine, and then we'll get into the details on COVID-19.
Thanks, Dan. Really excited to be here on the call. Glenview's, I'm very familiar with Glenview. Close friends lives in the Glen. I've got a brother-in-law and his family live right near Glenbrook Hospital and the high school over there, and my in-laws live in Northfield. So Glenview is really a very familiar place to me. So being hosted out of a family that lives in Glenview is really special to me. So I'm very similar to Dan. I'm an internal medicine doctor, trained for 3 years, so we know a lot about a lot. And it makes us good navigators and good caregivers for our patients. And I've been doing this for a bit longer than Dan. Over the weekend, I had a Zoom 25th reunion for my medical school class. We had about a third of the class on a Zoom call, and it was pretty special to see everybody after 25 years. Yes, my hair is a little bit more gray now than it was 25 years ago. Also, I have 3 kids, 19, 17, and almost 13. She's less than a month away, and she'll say, "I'm 12, Daddy." I was at the University of Chicago for 25 years, for 20 years. That's where I did my training after med school at Northwestern. And I opened this practice, Harper Health, almost 4 years ago, just because I felt there was a better way to care for people. Our practice is really designed around high quality primary care, try and be a one-stop shop for folks. And Debbie said it's like you're an old family doctor. Actually, our tagline is modern medicine, good old-fashioned care, because that's really what we try and do, is provide kind of a good old country doctor approach to care in the 21st century. And that's not easy to do in a traditional healthcare system, so our model is very different. It's almost like a membership at a health club or a country club, or it's just you're a member of our practice, and what that affords is each doctor has about 1/10 of a typical number of patients in their practice. So we tap out at about 300 patients, as opposed to about 3,000 to 5,000 in a traditional primary care practice. So you can imagine what level of service and care and attention that can provide you. And from our side, it's a much more wonderful way to practice medicine, to care for patients, is to actually have time where you're not rushed and you can give people the care and the attention that they deserve. So that's the kind of overview of our practice. As Dan said, we have 3 locations. We started in Streeterville downtown, the Northwestern campus, where we're all on staff. We've got the Hinsdale location, and now we've got our temporary spot until we build out our full-time space, but the temporary spot over in Skokie, which signed the lease yesterday. So pretty excited about that. So I'm going to kick it back to Dan so he can talk a little bit about COVID-19, like a summary of kind of where the science is at. And certainly, as I said, if you have any questions, please just type them into the chat or unmute yourself and go ahead and ask a question. Dan?
Thanks, Will. So I want to preface our comments today. There's always a disclaimer, which is that we're internists, we're primary care doctors. I think we're both pretty well read with respect to COVID-19, but we're not infectious disease doctors. We're not virologists. The other thing I wanted to point out is I think some people may have been getting the Harper Health blog, and this is really Will's baby. I don't want to embarrass you, but I think you put some very thoughtful comments into each of your blogs. I know I learn something every time I read the blogs, and I think they're a really good resource for our patients as we try and navigate the uncertainty that there is with COVID-19. So we'll talk a little bit about COVID-19. So in late 2019, there was the emergence of a novel coronavirus in people exposed to a seafood market in Wuhan, China, where live animals were sold. And initially it was reported as the novel coronavirus 2019, and subsequently was labeled SARS coronavirus 2, excuse me. The clinical disease that's caused by SARS coronavirus 2 is COVID-19. So just to say it again, the virus is SARS coronavirus 2, but the clinical disease is COVID-19. And SARS coronavirus 2 is a beta coronavirus similar to SARS 2002 and MERS 2012. SARS 2002 affected people in 26 countries, infected over 8,000 people, and killed 774 for a case fatality rate of 9.6%, according to the World Health Organization. MERS, the Middle East Respiratory Syndrome, as of January 2020, there were over 2,500 cases and 866 deaths with a case fatality rate of 34%. So these are much more deadly viruses than COVID-19. This is a very useful table when you think about the ideal pathogen. It's a table taken from the New York Times. Along the y-axis is the fatality rate or the severity of disease, and along the x-axis is the contagiousness of disease. So you can see that there are some pathogens like Ebola or MERS, the Middle East Respiratory Syndrome, that are really, really severe, but not as contagious. Conversely, there are pathogens that are really, really contagious, like chickenpox, but not as deadly. The ideal pathogen would be highly severe and easily transmitted. COVID-19 falls kind of along the spectrum that we talked about. So I want to talk about 2 public health philosophies. One is containment, the other is mitigation. Containment is used at the start of an outbreak, and it involves contact tracing. So they take someone who's got COVID-19 and they look back for 5 to 10 days, which is the incubation period for the disease, and they trace all the contacts that that person had and then quarantine those people and look for signs of disease. And this can go on and on and on in an effort to snuff out disease. I think of containment and mitigation a little bit. You can analogously think of it as a cancer where it's localized initially and you're trying to cure it. So with containment, really trying to prevent a larger outbreak. But once there's community spread, which is when there's spread that we can't trace it back to someone with known COVID-19, then you shift to mitigation, where you redeploy public health workers from contact tracing to helping consult the community and better prepare for what may be a wave of infections that's coming. And this is where you also hear about flattening of the curve to try and not overwhelm the healthcare system with too many cases at one time. So I thought we'd bring it back home to Glenview a little bit. I think it's difficult sometimes if you don't know someone that's had COVID, or if you're not managing someone that doesn't have COVID. It seems like it's out there in the ether. And I don't put these cases up to scare anyone or say that, I don't want to add hyperbole to this, but I do think it's important to realize that since 25% of patients may not have any clinical symptoms whatsoever, it is out there in the community. So the data from the Illinois Department of Public Health and the zip code of 60025 show that there were 178 plus cases. In 60026, which is also Glenview, there were 79 plus cases. So we can go ahead and take questions now. I have questions teed up that I can go ahead and answer, but if anyone has questions, we can also start with those. I'll just go ahead and start answering the question. Some reports say that for people over 75 or 80, catching the coronavirus is a death sentence. You know the percentage of people that age who are admitted to hospitals that live and come out just fine. So who is at risk? And then talk about risk. So younger patients do better than older patients, particularly patients over the age of 65. Healthy patients do better than patients with chronic diseases like cardiovascular disease, hypertension, diabetes, or patients that are on immune suppressing medications. Women do better than men. Caucasians do better than minorities. In particular, African-American population is overrepresented amongst those that are afflicted with COVID-19. Those people that are exposed to groups more often are more at risk than those patients that are not. Patients that are people that pay more attention to their 6-foot zone of safety that we talk about when you're out in public and wear masks are going to do better than patients that don't kind of follow the guidelines. And then similarly, where you live makes a big difference. So if you live in the middle of New York City, your risk is going to be different than if you're in a rural community somewhere. So these are some of the tables that we look about.
Can I pop in for a second? Hey, Dan.
Sure.
So that issue of the Keys, where there's one case and people are living their life normally, versus New York or Chicago or Detroit or some of these other hotspots. It really is the reason why, one of the big reasons why New York was such a hotspot was because of things like the subway, people living in apartments, really high density of folks where one person can spread it to quite a few people pretty quickly. And in other communities, like suburban communities or even rural communities where people are spread out, it's much more difficult to actually spread it unless you congregate into groups, such as a church function or concert or something like that. So the population health strategy to isolate folks in many communities made sense, like in New York and Chicago, but in other communities, it may not make sense. Like, why am I isolated when I live on a farm and I can't go into town to get the things that I need? So, the public health response was driven by what we were seeing in big cities. And I think as we begin to make plans, and Dan will talk about it, and I will talk about it later, as we begin to make plans to reemerge into the community, it doesn't mean that the risk is gone. It just means where there's a higher density of people, there's a higher risk of transmission from person to person.
Okay. So question 2, how does COVID-19 spread and for how long does someone shed the virus? So COVID-19 spreads from respiratory droplets if someone sneezes or coughs that can be temporarily aerosolized and then breathed in by someone else and lead to infection. Similarly, these respiratory droplets can fall on inanimate objects. So there was a study by the NIH showing that virus could live on cardboard for up to a day or on plastic or stainless steel for up to 3 days. If someone were to touch that surface and then touch their nose or touch their mouth, they could subsequently get infected. And this kind of shows why we have masks. We have masks out there to protect ourselves, but also protect everyone else from us. I think that the hard part about this disease is that 25% of patients don't have any symptoms from it. which is why this 6-foot zone of safety is so important. So when you're in your home, you know you're safe. You don't have to wear a mask at home. You don't have to be washing your hands repeatedly at home. But when you step outside of your home, it's a completely different story. You want to make sure that you're maintaining social distance from everyone, because you don't know who might be shedding virus that doesn't have any symptoms from it. We think that, it appears that patients can shed virus before they're symptomatic in the 4 to 10 day window. And then subsequently, how severe their disease is, they can be sick for 2 to 3 to sometimes 4 weeks. And then for 21 days after their symptoms resolve, they can potentially shed virus. So it's about a 5 to 6 week period where someone is potentially shedding and infectious for other people.
So then there's a question actually from Debbie about the younger folks who are having blood clots and strokes from COVID-19. Do you know much about that?
I just know that it's been reported. I think it was out of New York where this was coming from, where they saw a significant increase in the amount of patients under the age of 50 that were having large vessel strokes, which would be really, really uncommon otherwise. I don't know, Will, if you had any other comments on.
So there's some concern that COVID-19 creates a propensity to make blood clots. And that one of the concerns is that people who are in the intensive care unit and are on the ventilator, that blood clots are in their lungs, little teeny blood clots, making it difficult to provide oxygen to patients. And the same kind of blood clots can go to the brain and cause strokes. And kidney doctors have seen blood clots in the vessels going to the kidneys. So this concern about blood clots is an active area of research. And I reached out to a friend of mine who's a neurosurgeon in St. Louis to get his impression of what was going on with the strokes in younger people. And he personally, in his practice, because he's a stroke neurosurgeon, hasn't seen this, but the burden of COVID-19 in the St. Louis area is not as high as New York. So the reason why they can make reports about this is because they have a baseline, a number of people in New York that have strokes, and then they have a lot of COVID-19, and so they're able to make these assessments in a way that a lot of institutions may not be able to. So what that means is that there may be, even in smaller communities, if an individual under the age of 50 gets COVID-19, there might be an increased risk of stroke for that person. This is the challenge that all of us are facing in the medical establishment, is we don't have all the information yet. We rely on the research for the next 6 to 12 months as we learn more from all over the world about the impact of COVID-19. We're gonna get more information about this, but I think the take-home message is the belief or the supposition that, hey, I'm okay, it's not gonna kill me. Well, it may not kill you, but you could get a stroke. So deciding and how we open up the country and sort of allowing younger people to get sick, and some of the conversations around that, I think are a little premature because of the literature and the data that we don't have yet on really the true impact of this illness. So a good question. There's another question about like resources, like where should people go to get information about COVID-19?
I'd say one of the resources I think that we've been able to provide to our patients is the blog. And I think that that's a reliable resource to use, even if you're not a member of the practice. I mean, it's a publicly available web blog. I think the other websites that we have patients look at are the CDC. The CDC it's a difficult website to navigate and sometimes find what you're looking for, but the CDC is a good resource, as is the Illinois Department of Public Health, to look at those, those resources for information on COVID.
The other place that I direct people is, I'm sure many of you have seen the dashboard, the Johns Hopkins University dashboard of the impact of COVID, and they pull all the numbers in, and but they also have an email newsletter that goes out every day that summarizes the numbers, but it also gives some kind of up-to-date information on things like treatments and status of the vaccine, and pretty key information like that. So what I can do is I will put that link into the notes for that website, so you can go there and sign up for the email. So, and if you know, we have our contact information on the presentation, and if you have any questions afterward, you're welcome to reach out to us by email as well if you can't get it here.
So that's where you're getting your information, Will. It's not that you're scouring the internet, it's coming to you.
It's about receiving.
I see, go ahead.
Yeah, well, there's another, you got the question maybe about antibodies or testing. You want to, there's two different questions there. One's the tests and the other is the antibodies.
Well, so you're starting to see the market flooded by antibody tests under emergency use authorization by the FDA. And hopefully what that would allow us to determine is someone who's been exposed to the virus or potentially gotten over the virus. The hard part is that the presence of antibodies doesn't necessarily mean that you can't get COVID-19 again, or that you are immune to COVID-19. Similarly, you can sometimes have false positives where you get a positive result, the IgG antibody, but it's cross-reacting from another SARS corona-like virus. The antibodies can't necessarily rule out the presence of disease. You still need the molecular test, the nasal swab, which is looking for the virus. Because the antibodies don't turn positive right away, there's a window where you can be infected and you won't have detectable antibodies. But we're going to see more and more of these antibodies tests come out. And I think that they'll inform us a little bit more in terms of what proportion of the population is out there that potentially didn't have symptoms or wasn't diagnosed at the time that they were sick.
I think the key to the question about antibody testing. What's that? The key to the question about antibody testing and to know whether you've been infected or not, there's also, you yourself want to know if you're protected against illness, but there's also a population question as well. The more people that are infected and potentially immune, we can get what's called herd immunity. Some people have heard of herd immunity and maybe some people haven't. But if I am sick and there are 3 people in front of me who have never been sick, then there's a potential that I can transfer that to 3 people. But if 2 of those people are already immune, then the chances of me spreading it go down greatly, because now 1 person could potentially get infected. So you've really blunted the chances of an illness spreading for people that are immune. That's why we do vaccines, right? So we do vaccines, so 1 person with measles can't spread it to 12 to 15 people who haven't had measles. So the key thing about herd immunity, we need to get to, for different infections, a different level of herd immunity is required. So for a really infectious virus like measles, you have to have over 90% of a community immune to measles to prevent it from spreading and causing a local epidemic. That's why in anti-vaxxer communities, you hear of outbreaks of measles, because it takes 1 person, and once that 1 person gets it, poof, it's like spread to multiple people. And what's important about that, just to make one last comment about that, is not everybody who gets a vaccine develops immunity to the to a response to the vaccine. Vaccines aren't 100%. You get a measles vaccine, and you may be a vaccine non-responder. So 95% of people who get the vaccine actually become immune to it, but you have 5% of people who get the measles vaccine who are still susceptible, even though they wanted to try. So that's why vaccines are so important, and that's why this idea of herd immunity is so important. And for a virus like SARS-CoV-2, we need about 60% of the population to be immune before it stops spreading like wildfire. Okay? In New York, we're at about 20%. In the hardest hit place in America, they're at 20% immunity. They got a long way to go. So that idea of antibodies is important, but it's a long-term process as we go forward. And the final thing to say about I think you may have said this, Dan, but to reinforce, is that the presence of antibodies, your body's response to the virus, does not 100% guarantee that you're actually protected from getting it again. It's likely, but we don't have the research yet to prove that getting it once protects you from getting it again. So this is the other kind of part about it. We got to wait a little more time for the research to get done for us to prove that people who get it are protected from getting it again. We just don't know that for sure.
Will and Dan, can I make a quick comment?
Sure.
Well, two comments, and they're both, they start out as Zoom comments. I'm wondering, I'm hearing a lot of funny feedback as you were just talking, Will. And I'm wondering if, along with all the rest of ours being muted, if one of you are talking, the other one might be better muting theirs. Because I'm watching the microphones here, and as you were talking, Will, Dan's kept going up and down as if he was talking. So somehow I think there was some feedback going on.
Thanks, Rick.
And the second one, Dan, I sent you a chat. Did you get it?
No, I didn't see it, Rick.
I sent it a while ago, so I assumed you hadn't seen it. You probably have to open up the chat.
Dr. Harper, there's also a couple of other questions that
I see them.
came early.
Yeah, we'll get to them. Mm-hmm.
Thank you.
Did you have a question, Rick, that you wanted to ask?
Sorry, the question I sent by chat was if you would talk about the challenges of air travel.
Right.
It's a pretty open question, but you hear a lot about staying 6 feet apart, wearing a mask, but that doesn't mean you can still be safe, even 6 feet apart. I hear about, extended exposure as a problem versus short exposure. All that seems to not work in an airplane.
Right. I mean, you're in a contained environment, and even if they're maintaining social distancing at every other row or however they're going to try and spread out the people in the plane, you're still at risk in a closed system. I think for the most part, I would try and avoid air travel for the time being. I think if you had to do air travel, you would want to try and get an N95 mask that you could wear on the plane. I don't know, Will, if you have other thoughts about what to do for air travel.
As with any activity we do, the moment we start going into a group, the larger the group, the greater the chances that somebody's going to have COVID-19 and not know it. So in a group of 5, it's just, now you get on a plane. So now you're or even walking through the airport, you got groups of people. So when you're walking by somebody, not a big deal. But when you're sitting next to somebody for an hour, 2 hours, 3 hours, within that 6-foot zone of protection, somebody that's not invited, like your spouse or children, now you've exposed yourself. Now, if you're protecting yourself with an N95 mask and it's fitted properly and everything's, perfect, then you're probably going to be okay. But we have to guarantee that it's the right N95 mask, that it's, you know, passed what we call the sniff test. And so there's no 100% guarantee there. And the other challenge with air travel is that they recirculate the air. And supposedly, you know, there's good filters and HEPA filters that are actually pretty good at filtering out bacteria and viruses. But you're relying again on the airline industry to be doing a good job servicing the plane. My belief is that the airline industry is really desperate and they're gonna do whatever they can to assure their passengers that they're doing everything to make the plane safe. But there's really no guarantee. So it's all about how much risk you're willing to take on and how much you can mitigate that risk. And that is going to be decisions that people have to make on a regular basis.
Yeah, I think I agree, Dan, with your advice as well.
Can I ask a question? If you have a cotton mask, you know, like a homemade mask, and then you put a coffee filter in the mask, does that help anywhere? I mean, like.
So all the masks are on a spectrum, right? So at one end of the spectrum is being at home, not exposed to anybody, and then you walk out of the house. So once you get out of the house, you've got an N95 mask, which is kind of the top of the line. And then you go all the way down to, there's probably something less effective than a cotton mask. The purpose of the mask, when you're wearing an N95, is a little bit different, but anything else, it's really to protect other people from you. That's kind of how it's designed. And if Dan goes back to one of his original slides at the beginning, you can see that really the purpose of the mask primarily is if you're sick, to protect others from you, okay? So in that first, as you can see, the probability of contagion. So when the person has, when you have the mask on and somebody doesn't, that second one from the top, there's still a high risk of infection. When you put the mask on the other person, there's a medium risk of infection. Flip it around. So while the mask protects you, it doesn't protect you quite as much as if the other person is wearing the mask to protect other people. That makes sense?
Is there a point when we would feel comfortable wearing those masks? Because right now, you feel you were taken away from the first responders.
Okay, so let me answer her question first, so then you've got the cotton mask, and then if you put something else in there, so if you put a coffee filter, or if you have an old, filter from or not an old one, but a new one, filter for your HVAC unit, and cut out the filter there and put it into the mask, it is going to provide more coverage and more protection for you. But you want to make sure that when you're breathing, that you're breathing actually through the mask. Because what I've seen sometimes when I'm wearing my own, walking my dog, is that the air seems to come in over the top or around the sides, and it's actually not coming through the mask. So if the mask is too thick or it's on really loosely, you may not actually be getting a lot of benefit from it, because the air can just kind of go all around it, which is why the surgical masks that have a little kind of thing around the nose to kind of put a little tighter, and obviously the N95 mask, which is really good and tight, those things really force the air to go through the cotton or through the N95 and filter actually before it gets into you, okay? So everything helps, but just make sure it's a little tight. That mask is a little tight so it actually forces the air to go through the cotton and not around it, okay? So you ask, is there a point when we're taking it away? So the summertime, we're gonna start seeing the cases go down, okay? And what that's gonna allow is actually the supply chain to improve. And as the supply chain improves, hospitals and healthcare institutions are going to stock up. And once they feel like they've got their stock, we're going to start seeing them get back on Amazon. We're going to start seeing them getting back into the public domain. What I'm doing for our patients, the whole practice, is I'm actually trying to secure N95 masks for all our patients. So if you're a member of Harper Health, crossing fingers, I've got somebody who's trying to send me some. I'm actually going to try and secure these directly from China. I'm not taking them from any healthcare providers here. You know, they're from a reputable supplier, and I'm not getting 5,000. I'm only getting what I need. But I'm going to be able to, you know, provide that for our members so that when they go out into a high-risk environment, such as hopping on a plane because they have to, they'll have something to protect themselves. And there was a question about having chronic illness, like an autoimmune disease.
Right. It says, is there a higher risk of serious illness with COVID with autoimmune diseases like rheumatoid or psoriatic arthritis? I think that we think that there would be more risk because depending on the treatments that someone was on for rheumatoid or psoriatic arthritis, that might predispose them to a worse infection with COVID, but I don't know that we actually have data to support that at this point.
There's also a competing, again, we're learning all this in real time, but there's a competing school of thought that some of the medicines that are being used, some people may have heard of the cytokine storm. You know, like people with, there's a double illness for people who get severe COVID-19. People get really sick and they go to the intensive care unit and they're really sick, and then all of a sudden, boom, something happens and this cytokine storm hits and the body's immune system flares up super high, and then they end up on. There's some thought that some of the medicines that are used for autoimmune diseases might suppress that cytokine storm. So that's some of the areas of research that's ongoing that, you know, hopefully in the next, 6 to 12 months, we'll learn more. But it may not necessarily be, depending on the medicines you're taking, may not necessarily be that you're worse off. What about asthma? Have you read about asthma, Dan?
So my wife has asthma, so this is kind of a near and dear to my heart. She asked her allergist, who's actually out of North Shore University, and they were saying that there actually is no increased risk that's been borne out in the data. There's been no increased complication rate in patients with asthma. It would make sense that if someone had a lung disease, potentially they would be more susceptible to bad disease with COVID, but that's not what the actual numbers are bearing out.
Looking. So what about the remdesivir?
So we could talk about treatments.
Yeah, you want to talk about treatments?
Are there effective treatments for COVID-19? Yesterday, I would have said there are no effective treatments for COVID-19. It appears that remdesivir, which is the third one down here, which is an antiviral that was initially developed to treat Ebola, showed that it could lessen the severity of COVID-19, I believe was the wording that I saw. They also tested that medication in a 5-day period versus a 10-day period, and apparently it was just as effective at 5 days as it was 10. But the rest of these therapies that you see up here are Plaquenil, which is hydroxychloroquine, and azithromycin. So Plaquenil is an antimalarial medication. It's also used in patients with rheumatoid arthritis and lupus as an immune modulating agent. There was some data that was out of France initially that was showing that there was reduced infectivity for patients that were on hydroxychloroquine and azithromycin, but it hasn't been confirmed. And so there are trials ongoing for that. Kaletra is an anti-HIV medication that was tried. And there was actually a randomized control trial out of China with about 200 patients that showed that there was no benefit to Kaletra. And then we also hear reports of convalescent plasma. So that's taking the plasma of someone who's been infected and in theory has antibodies and administering it to someone who's severely ill with COVID. And there have been case reports of patients doing better with convalescent plasma. And then there's the IL-6 therapy. So Will was talking about the cytokine storm. When you get ill with COVID, there's this massive inflammatory immune response. And so one of the thoughts is to attenuate that immune response, which can be counterproductive when you're severely ill with COVID-19. So there are IL-6 therapies that are being tried to kind of attenuate the immune system in patients with COVID-19.
What do we do with remdesivir with that information? I mean, it's used in hospitalizations. Do you think there's a chance that it's going to go out to a lot more people?
You know, I don't know the answer to that actually, Will. Why don't you answer that question?
You know, this is kind of the exciting part about learning about something like this, getting this data. You know, if it lessens the severity of illness, maybe it can be used early on in the course of illness in order to prevent somebody from entering the care unit. So this is the first step of many as to whether remdesivir can be a solution, because what everybody on this call wants to know is that if I get sick, am I one of those people that's going to end up in the intensive care unit? You know, is that going to be me? And if you know that you can call Dr. Dan and get a prescription for remdesivir, and that you're very unlikely to end up in the intensive care unit, that's a home run. That changes the way that we think about this disease. So this is the first drug, and I know there's going to be other ones that are being studied and that are going to come out. So, you know, when I think of the future, when I think of kind of the next 6 to 12 months, we're not going to be on quarantine for 2 years. We're not going to be behaving like, you know, walking around on eggshells for 2 years. Science is so powerful, and we have people all over the world studying this, that I believe that remdesivir is just the first of a few different medications that are going to be found to be helpful. Yes, the next 6 months to 12 months, we're going to have to be cautious, particularly in areas of higher prevalence like the Chicago area. But I think that we're going to have some solutions that are going to help us be a little more comfortable with coronavirus as we move into subsequent seasons. That's really my prediction, but you know, we can come back in a year and you can tell me whether I was right or not. Let's see, what other questions do we have here?
Remdesivir is an IV drug, Rick. You were asking about that. So it's something that would have to be administered to inpatients as it is now. It wouldn't be something that we could give to an outpatient.
Right now, I don't know what the oral bioavailability is and how they're able to put it into a capsule, and you know, so that's the other more of the future and how we can learn more. What about the issue of the summer and how that's going to change things?
Well, there's the thought or the theory out there that with warmer weather that the virus is going to wane, and then there's the thought that when it gets cold out again and it's cold and flu season, that the virus is going to come back and there's going to be this second wave or subsequent waves that we see of virus. And I think what we're going to be doing, hopefully, is very thoughtfully removing restrictions, but what we're probably going to do is toggle back and forth between more efforts to contain the virus and then mitigate if we see data that's suggesting that the virus is coming back. So in any prudent strategy to start easing the restrictions, we're really going to have a lot of testing that's informing us as to whether or not the virus is becoming more, is increasing in frequency again. Yeah. Did you have anything you wanted to add, Will?
I think that pretty much nails it. You know, the more we know, I think George at the beginning said we're going to try and keep politics out of it, but I think it's not necessarily politics, but it's more legislation. And, you know, I'll use Georgia as an example. a county in Georgia that has a lot of COVID-19. And as many know, Georgia opened up their, some of their businesses to service again. But this one county is really in a bad spot. So if counties and cities own decisions about if there's a hot spot, and they could make their own decisions about shutting down a county, that might be good for the people of that county. However, what are the implications for unemployment and unemployment insurance? And, that there are a lot of details that would have to be worked out in order to do that and to achieve that. And so sometimes it's the political will of a particular region or the interest in getting into the nitty-gritty of the details of how to achieve that. That's really the challenge of both public health as well as politics. But ideally, the way that Dan laid it out is right on the money. It's if a country or county has a flare up, you shut it down, let it calm down, everybody, isolate them. And then once things get back, and things calm down, you open back up the county. I don't know if it's going to work that way, but that could be a way that we open things up and allow for some flexibility in hotspots and let people, feel more comfortable going about their lives. George asked a question, Dan, about, what do you do if you get it? How do you get through it? What can you can you do anything to reduce the severity?
So just to answer the question, if you think you have COVID-19 symptoms, what should you do? You should contact your physician. Hopefully you can get on the phone with your physician, describe your symptoms, and get an idea as to whether or not there's a high likelihood that you have COVID-19. You should get tested. One of the things that we've been able to do at Harper Health is do some drive-by testing in our Hinsdale location, swabbing people's noses and doing the antibody test to try and determine whether or not someone actually has COVID-19. The second thing you should do is self-isolate. So you want to, if you live in a household, if there's a bedroom that you can kind of cordon yourself off in with an adjacent bathroom that's kind of labeled as contaminated, so that other family members aren't exposed to the virus. And similarly, those family members should be quarantining themselves for 7 to 14 days to make sure that they don't come down with symptoms of COVID. And lastly, you should really be self-monitoring your symptoms. What we really want to know about is your breathing, because of the dreaded COVID pneumonia or superimposed bacterial pneumonia that patients can get. So if you're starting to feel short of breath or starting to feel like you can't complete full sentences without taking a breath, that's something that you should really bring to the attention of your healthcare provider, because that's a sign that you need a higher level of care. There have been some patients that have bought pulse oximeters and are using those at home. I think that that's useful, but oftentimes by the time the pulse oximeter starts to dip below 92 or 90%, you're probably already at the stage where you should be evaluated in an emergency room or in a healthcare setting. So if you catch the virus, what's the best way to get through it? I think you have to have faith in the institution that you're going to present to. I think Northwestern is the premier tertiary academic medical center in the city. And you know that you have all the resources of Northwestern coming to your aid. Northwestern is part of the remdesivir trial, and hopefully you could get remdesivir. But similarly, the quality of the inpatient staff and the ICU staff is incredibly important when it comes to illness like this. You don't want to say anything negative about the community hospitals, but Northwestern really has a lot of resources they can bring to bear if you're in a pinch with a really bad COVID-19 infection.
And the people that I know who've had it, the fever is probably one of the worst things. One of my patients was having a nightly fever up to 103, 104 degrees, which is really intolerable. And what I, again, hopefully if this were ever to happen to you, have contact with a doctor to help you get through it. But the fever taking and the timing of taking anti-fever medicines like Tylenol, if you feel once the fever was going up, what she learned is if she could keep her temperature below 102, it wouldn't be as bad. So she would time the Tylenol with when the fever would come so that her fever wouldn't be as bad. And the fever actually serves an antiviral purpose. Viruses, it's a defensive mechanism for our body to fight disease. And viruses don't like temperatures in the 100, 102 degree level. So at some level, if you can handle the fever, take it, because that's going to help your body get rid of the illness. Within, the first few days of being sick, trying to understand how your body is responding and how it's making you feel, and then taking the medicine that can help attenuate some of those symptoms. That's the guidance that, I provided her, and that, she got through it, but it was a pretty tough 2 weeks. Debbie asked if testing is becoming easier or more available.
We're certainly, the turnaround time on testing has gotten a lot better. There was a time when we were doing a LabCorp swab, which is our preferred vendor for the lab, where it would take up to 8 days to get the swab back. But now with some of these new automated assays, they're able to run a lot more tests a lot more quickly.
Yeah, and I think
go ahead.
these antibody tests, as I mentioned in the email today, Quest is, you don't need a prescription. You can just order it yourself and get an antibody test from Quest. The issue, though, is the quality of the test. As I was talking to somebody today, I forget who, and the quality of the test right now is, if you go to Quest and get the test result, in a population that doesn't have a lot of, it's not like New York. So let's say, for a community like Glenview, if you go to get the test and it says that you have IgG antibodies, so it's that, like, oh, you have the antibodies. It's actually based on the statistics, a 50-50 chance whether it's actually a truly positive test. So we need better than that. And so it's going to take a little more time to get the better test. So, again, sort of in consultation with your doctor, I think is really the most important take home. Should you get tested? What test to do? Am I feeling sick? Was I sick? Did I have it? Those are the kind of services that and answers and questions that we get all the time, and we're trying to answer for our patients. I posted in the chat the link to the Johns Hopkins website. It's the news page, and then from there you can get on their newsletter, which comes every day about 11 o'clock in the morning. So Suzanne asks, can you further explain the 50-50 answer? So I was not the best at statistics in school. So I rely on a lot of people to help me with this. But anytime you do a test, whether it's, a blood count or a strep test or this COVID-19 test, no test is perfect. No one test is perfect. Even when I do a strep test on somebody and it's negative, there's a chance that I swabbed it in the wrong place, or, I just didn't get enough bacteria for the test to be positive. So that's called a false negative, because it was truly positive, but I got a negative test. And And the sensitivity of the test is important. Like, how good is it at finding the disease? You know, if you really have it, how good is it in finding it? And then the opposite to that is the specificity. If I don't have it, how good is it at telling me that I really don't have it? So those two numbers are critical for every test. Okay? So that sensitivity and specificity for the test that Quest is doing is okay. It's not great. And, you know, the statistics lecture about this, about sensitivity and specificity, when you then apply it to a population of people. So if you don't have a lot of disease in a population that isn't very common, there's a good chance that when you get a positive test that it's not really positive. It's because it's falsely positive. So based on COVID-19 testing, based on the tests that they have at Quest, and based on, we're not New York City, a 97% specificity doesn't predict that a true positive is really a true positive. It's just a 50-50 chance. So that particular test is not the best yet. In our patients, so if somebody had an illness that was very suspicious for COVID-19, and we did the test and it showed a positive, we would tell them that it is likely, more than 50%, it is likely because of your symptoms that the test is truly positive and you do have the antibodies. So it's in those people that never had a symptom, didn't have many contacts to people with COVID-19. You do this antibody test, there's probably not a good chance that you had it. So if it comes up positive, I'm not sure I believe it. So that's the challenge with testing and where it is right now. So Luann said, this is so discouraging all around. Is there any good news?
I think the remdesivir news from today is really good news. I mean, now we have a therapeutic that we can potentially give that will maybe not cure the disease, but improve survival. I think that was very good news today.
And I think the other piece of good news is all of the efforts that you are making, all of the, stay at home, and it's working. The rate of increase of cases in Illinois is flattening. And, we need 2 weeks of declining case numbers in Illinois. And once we get to that 2-week mark, then we can start talking about a phased opening and getting ways to get out of the house a little bit more. So that's the recommendations from the White House and how state of Illinois is interpreting it. 2 weeks of day-to-day declining case numbers. And we're not going up anymore. We're pretty flat. So next is going to be a decline. And that decline is coming from all the hard work that people are doing, trying to prevent the spread from person to person. So to me, that's really good news, because with every case, there's a chance of somebody dying, and that somebody is a loved one. It's somebody's mom or dad or sister or brother. And so this is all, to me, really good news that we're hopefully, on the downside in our state and in our region. Yeah, so the follow-up question, Suzanne, is a good one. Don't we get more and more cases just from more testing? Dan, you want to take a stab at that one?
Yeah, so we do get more and more cases from more testing, but in general, those are patients that probably have minimal symptoms and aren't as severe. So you're actually going to see the death rate of COVID-19 come down with the more cases that you find. Because in general, those patients are not as severe. They're not coming to the hospital. I don't know, Will, if you had anything to add to that.
Yeah, just, I think maybe your question is around, if we're testing more, is there a greater chance we're going to catch more people? And if that's the case, will the case numbers go up and then we're further away from the 2-week period? That is a possibility. The other upside of finding more and more potential people who have mild cases is, if you remember, we talked about the herd immunity. If we find that a mild case gives you enough immunity for protection, the more people that are potentially mildly infected, the quicker we may actually get to herd immunity. So that's another upside, another potential piece of good news. So I wish we had stronger research that we could present, but hopefully, what we've talked about today was useful. Are there other questions that people wanted to ask?
Why did herd immunity fail in London?
Dan, do you know much about that?
I don't.
Yeah, so when COVID-19 first came to the UK, Boris Johnson and his experts wanted to just let it go, let it run rampant and see if we could get to herd immunity. But from a let's just say a humanitarian perspective, that's not really a good choice. It's not really an ethical response to it, particularly when we consider the people under 50 who could have had strokes, the 30-year-olds who are actually in the intensive care unit don't die but end up with chronic lung disease as a consequence of their illness. So the idea that we were just going to, let our population of Britons, see what happens, and I think the smarter heads prevailed, and they decided to not take that route, and instead decided to do the quarantine. That's my understanding of what the UK did. Did you have a different? You said specifically about London. I don't know anything specific about London.
It seemed like a total failure, and I just wondered, like you talked about herd mentality here, and I'm just wondering why it would be more positive or work better here than it did in London.
Yeah, so it's just ideally what you want is to get herd immunity through vaccine. You want to get it through the vaccine, not through people getting sick. And so, but if you can get closer to herd immunity by people having mild illness, and then you only need to vaccinate those who need it, the burden from a public health perspective is much lower. So the next, 6 months, as we learn more about whether having the antibodies actually protects you, that's a key piece of information. Did you actually get protection from the antibodies? The second is, how sick do you have to be in order to get the antibody? Can you have a mild illness, and is that enough to give you the antibodies that are protective? And then third is, how long do those antibodies last? Does it give protection all the way through to the end of the cycle of illness? Let's hope. And then the fourth is, do we have a vaccine to protect those who haven't been sick?
Okay.
So by those things all together, you want to get to that 60%.
Do you think that Sweden is doing much better with how they are handling this?
Not at all. Not at all. I actually just, in my blog today, I use Sweden and Norway as examples. For those of you who don't know, like, Sweden is actually one of the only countries in the EU that hasn't done social distancing. They haven't done, the quarantine at home work. And Norway, their neighbor, did. And if you look at the Johns Hopkins website, you can actually see that Norway flattened its curve a month ago, and Sweden has yet to flatten its curve. The population of Norway is twice that, the population of Sweden is twice that of Norway, and they have 10 times as many deaths. So their solution is not working, hands down.
Okay.
Well, the choices that we made in America to quarantine at home, those were the right decisions. And you can point right to Sweden as an example of and their next door neighbor who did what we did. You can see kind of night and day the difference.
Thank you.
A layer of nylon pantyhose, when added to mask, is shown to bring it to medical grade level. Well, that's some research I'd like to see if we trust NPR. Well, I do trust NPR. But I would like to see that data. But that, I don't have any pantyhose myself, but I'll have to talk to my wife about whether she's willing to sacrifice any. Did I miss anybody's questions? Did we miss anybody's questions? Dan, anything else that on your slides that you think would be important for us to pass on?
No, I think we pretty much covered it.
Well, I want to first off thank you both for taking the time to do this. Answering everybody's questions till they're done sometimes doesn't happen, and that was really very gracious of you to do that. And Deb, I don't know if you want to add anything else, but I would, for those that are interested in your concierge medicine practice, would you mind just giving a minute for anybody that wants to hang on for that to do that? But Deb, first, is there anything else you wanted to say?
No, I was just going to say thank you. This is really very informational, but really, really helpful. And if you guys do another one again, let us know and we can jump on again. Because like you said, the information changes daily. So
It does. We're happy to be here. This is, if we can educate you and you can take that and educate a couple people, and, we want that kind of stuff to spread.
mm-hmm.
Not
Mm-hmm.
COVID-19.
Mm-hmm. Exactly.
We're happy to stay on.
Yeah, so I mean, is there some contact information of where we, everybody has their individual needs. I certainly wouldn't want to ask anybody
Right.
to do that, but there we go. That's what I was looking for. If we wanted to put that up, that's very helpful. Thank you. And will that be included also in your, in the information, Dan, that you guys will circulate?
You mean the blog?
So we can, we'll circulate the recording of this. However, I don't know about your, the emails and how they spread out. Or
Yeah.
share our contact information, and you can pass that and shoot that forward to your.
Yeah, maybe that's the best way to do it. If you could send that, Dan, then we can send that along with, here's how you can hear the recording.
Yep.
And
Yeah,
it would give and that would give people the opportunity. Thank you.
Perfect. Yeah, that sounds great.
Thank you, guys.
Oh, thank you. Thanks for all your time and information. We really appreciate it.
It was nice to meet you all and spend the evening with you.
Thank you.
Thank you.
Thank you.
Thanks so much.
Thank you, guys. Bye, guys. Thanks.
Good luck.
Thanks.